Assalamu alaikum and good evening. I welcome you all to this ROP symposium, and I'm very pleased to see all the attendants present here on time. I would like especially to welcome Dr. Khurram Mirza and Dr. Sarfaraz, the legends in retinopathy of prematurity, doing a big bulk of retinopathy of prematurity patients. Our first speaker today is Susanna Tierra. Is she there? Then we can have presentation by Dr. Fatma Mahmood from Fatma Memorial Hospital. She is doing the ROP screening at Fatma Memorial Hospital. Please, Dr. Fatma.
Assalamu alaikum. Good evening. Should I start? Sir, should I start? Okay. विकास इधर से खड़े होकर पिक्चर ले लेते हैं. ये ओके थैंक यू. ठीक है ओके सर. शुड आई स्टार्ट? सर शुड आई स्टार्ट? Assalamu alaikum. My name is Dr. Fatima Mahmood and I welcome you all to this session. So, Bismillah Rahman Rahim and okay, so as we all know that retinopathy of prematurity is a complex retinal disease and it is due to abnormal or incomplete retinal vascularization. It is a disease of preterm infants. Oh, so, okay, so coming to the epidemiology of the disease in Pakistan, roughly it is 10% and the major risk factors are low birth weight and low gestational age. As we all know, the etiology of this disease is biphasic. There is early vaso-occlusion resulting in hypoxia, and then this hypoxia in turn led to the formation of new vessels and then the sequelae of the disease. As I already told, today we have to discuss the outcomes of screening of retinopathy of prematurity in the setting of tertiary care hospital. Okay, so this study was done in the pediatric NICU of Fatma Memorial Hospital in collaboration with the two departments, neonatology and ophthalmology. The number of patients were screened in a particular period of time. There were 18 newborns and detailed history and ophthalmic examination was done. After pupillary dilation, retinal examination was done with 20 diopter with indirect ophthalmoscope. So I received 3 patients of APROP and as I'm only doing screening, I referred the patients and they were managed. Thank you to Lahore General Hospital and Dr. Lubna and team of Professor Moin. But the striking finding which I found and which was the most common finding was presence of peripupillary pigmentary halo and arteriolar attenuation. The second most common finding was retinal thinning and prominence of the choroidal vessels. Both of these findings were pointing towards the future propensity of myopia in these individuals. And apart from that striking finding, I also saw a kid of vertical CD ratio of 0.9, and I was planning examination under anesthesia for glaucoma assessment, but unfortunately I lost that patient. And one patient was of Valsalva retinopathy. There was 0.3, 0.4 fresh premacular subhyaloid hemorrhage on both the maculas of the patient. And on probing the history, I knew that the patient had multiple intubation and extubation, a long stay of NICU, and prolonged spells of apnea. That patient was followed for 3 months, and the hemorrhages were absorbed, alhamdulillah. So as I told earlier, the most common finding was peripupillary pigmentary halo, leading to future propensity of the myopia. Also, so coming to the conclusion of my study which was done, any child who is underweight, and as we all know that we are following the screening criteria of 200 grams and less, and gestational age of 34 weeks and less, every child should be screened. If any ophthalmologist is not doing ROP screening, kindly refer the patients to the center. And unfortunately, in our part of the world, there is no proper awareness. There is lack of general health facilities, and there is lack of collaboration, I must say, between the pediatricians and the ophthalmologist. So these are the things which need to be encouraged and need to be developed. So my take-home message in this slide is, when you are screening a newborn for retinopathy of prematurity, if you find other findings other than retinopathy of prematurity, please do not overlook them. There should be proper referral system, and public awareness should be done. And there should be collaboration between the neonatology and pediatrics department. Thank you so much. Thank you. Any questions? If you want to ask.
Just
No.
let
Yes, sir. Thank you. Exactly, sir. This is the emphasis of the, actually, I don't have much slides or anything, but this was the take-home message, that the ophthalmologist and the neonatologist, both of them are equally involved. Unluckily, at my hospital, Fatma Memorial Hospital, the neonatologist, Dr. Zahid, he's very keen. I was telling Professor Moin in the last meeting that he's very keen, and he makes sure that I come every week and screen 4 to 5 patients. And I was very happy when I compared it with the other hospitals, that they were doing no screening. So every child who is fulfilling the criteria, he or she should be screened, and no child should go blind for this. Thank you so much. Yes, sir. Also responsible, exactly. Sir, in our last meeting of retinopathy of prematurity, we were discussing this, that an obstetrician, gynecologist, and a pediatrician should join our meeting, and they should raise awareness as well. Because if I, as an ophthalmologist, I'm telling the mother who is exhausted and with other kids at home, she will not listen to me. And if the pediatrician and the gynecology, they will reinforce for screening and for follow-ups, so that this will have a major impact, and no child will go blind. Thank you so much.
Thank you, Dr. Fatma, for a wonderful talk. Now I would like to invite Dr. Susana from Portugal, and she will tell us about the surgical treatment in ROP patient, tips and tricks for stage 4 and stage 5 ROP.
Thank you. Thank you very much. So we are going to a completely different subject, that is the end of the history. So if the screening fails, if the treatment fails, we go into the surgery. So this was and is a talk for people from vitreoretinal surgery. So vitrectomy in ROP is a very stressful disease. It's technically difficult, emotionally difficult. At the end, you have a room, you have a surgical room full with people, and your aim is just that little tiny baby, the eye inside a little tiny baby. So what I advise is don't book this surgery in a very crowded day. So take time for this surgery. It's the first tip for this surgery. Then, you know, the eye is very little, so has things very specific of the eye. It's a very small eye with a very big lens. What makes it very difficult to get inside the eye without touching the lens and without touching the retina. So that's the second challenge. You can have a lot of algorithms, but really, after reading all the algorithms, it's just you and the eye. And as you can see, there is almost no space to put the trocars inside the eye. So for putting the trocars safely inside the eye, I use retroillumination of the pars plana. So with the tip of the light, you see the lightening of the little pars plana of the baby. You measure it, and then in the different quadrants where you want to get inside, you do this. So you put a light in the sclera, see the pars plana with light, and then you put safely your trocar inside and avoid the lens. Then the trocar is very big. Oh, before the trocar is very big. The ROP detachment is a tractional detachment that can have different configurations. So you are free to put in different places the trocars. I mean, you put the trocars away from the detachment. It's not like in the adults, you put 2, 5, and then inferiorly, the infusion, no. Here you put everything away, freely away from the detachment in order not to touch the retina when you get inside. Trocars are too big for such a small eye. Sometimes we have tricks to not put too much trocar inside the eye using the encircling band. Cut a little bit the encircling band and put between the sclera and the trocar, so there is not so much trocar inside the eye. Then we have a vitreous gel that is nothing like the adults. It's really a gel. And in the baby, the premature baby, there is no anatomical plan between the retina and the vitreous, so you cannot dissect safely like in the adult. And as you have a thick vitreous and an embryonic vitreous still inside the eye, you have traction forces that must know very well when you get inside the eye. So when you get inside the eye, you must read the eye and know exactly where are the anterior posterior tractions, where are the centripetal forces, as you can see, and where are the tangential forces. And tangential forces in this baby are very hard because they are linked with the flat neovessels that are linked with aggressive posterior ROP. And when you have retinal detachment secondary to aggressive posterior ROP, you have one of the most difficult detachments, as it has a volcano shape. So it's a volcano shape. You have all the embryonic retina covered with fibrosis and suspended to the pars plana. In my experience, it's very difficult to open this closed funnel, but you can desuspend it, so cut all the peripheral tractions and allow the retina to slow a little bit, to settle a little bit. So you can see the funnel. This is a complete funnel. I separate from the periphery and just to laser. Then I try to shave a little bit, but in the ROP surgery, less is the best. I mean, you cannot make a hole, you cannot touch a vessel, or everything is lost. So ROP detachment, retinal detachment, is a tractional detachment. So we must not transform it in a rhegmatogenous. Another tip is there is a quick progression from stage 4 to 5. I mean, we can say a baby with stage 4, in this case 4A, and I didn't inject the baby because he was very sick, and I just make the surgery, I'll try to make the surgery, 3 weeks later. And 3 weeks later, it was like this. So it's incredible the way a stage 4 proceeds to a stage 5. So always look at the baby the day before the surgery or in the day of the surgery. And it's a do not surgery. So you cannot touch the lens because you can have a wonderful surgery and then an amblyopic baby. Do not touch the vessel, because if you have a bleeding inside the surgery and the eye is full of blood, again, the surgery is over. And do not touch the retina, because you will have a completely impossible retinal detachment. And always look at the retina at the day at the surgery before you put the trocars inside the eye. We have a lot of techniques: the scleral indentation, open sky, that I never did, vitrectomy with lensectomy, and lens spare vitrectomy. That is the one that we try to do it in earlier stages, 4A. And what do? We get inside the eye, look at all the pictures, try to see where the vectors of traction are, and we begin to not dissect, but make a central vitrectomy and take these first forces. I mean, the blood, retina, blood, and you try to leave these forces, posterior forces. And when you stop, it's over, dissecting these posterior forces, then you come anteriorly. As you can see, you come anterior. And anteriorly, you have layer by layer by layer. So you have 365 from this layer, then the other one, and then the other one. So I advise you take layer by layer, because you never know where the retina is. The retina suddenly can be anteriorly, and you can cut the retina. So layer by layer, layer by layer, you see the thickness of this membrane. Layer by layer, you are making 360 degrees of cutting these anterior vectors of forces, membranes, and then at the end I used to do laser of the periphery. And I think it's a good result, specifically this case. Do I have time to another case? So,
Do please.
do I have time? This is a late referral, stage 4A, late referral. So I saw the baby this way. I injected the baby with anti-VEGF, and I make the surgery. And in this surgery, it's exactly the same method. You get inside the eye, look, and try to read all the forces, the traction forces, and just cut the traction forces and allow the retina to go to its place. So you do anything more than that. Look where you see the traction forces, you see the membranes, you feel the membranes, those membranes here. So you feel them, you cut them. If you need, you can use triamcinolone to be sure that you separated the retina, as I'm doing here, to be sure that I separated the retina from the periphery, and you just do that. Cut, allow the retina to go to its place, and 2 or 3 months later, it's okay. It's a nice. This is 1 year later. You can see the traction in the choroid, but the retina is settled. Stage 5 is not this. Stage 5 is almost impossible. I show you another funnel. It was a volcano shaped, and you cannot do anything, because this was still a very, although I injected anti-VEGF before the surgery, it's very active, this kind of ROP. And here we do always the same. Cut from the membranes to the periphery, the tractions to the periphery, allow the retina to settle. The only problem is when you try to dissect this posterior volcano, you have vessels, very active vessels, even after using Avastin, and they bled. So when the bleed begins, the retina, you see, it's impossible to control the bleed, even with higher pressure and all that. So I'm skipping this. We can try to use ochraplasmin, something to dissolve these vitreous, but it was not surgically effective. And my take-home message is that I'd rather not to make vitrectomy. I'd rather to have a good screening, as the colleague told. It's fundamental. It's a good screening, timely treatment, and avoid vitrectomy. But if you have to make a vitrectomy, the best stage to do is stage 4A, the best results, anatomic and visual results, very good. And always see the eye before in the day of the surgery to be sure that you don't touch the retina when you get inside. And that's it. Thank you.
Thank you very much.
And I'd like to thank my host. It has been an incredible meeting. Thank you.
Thank you very much. This was a wonderful presentation here and beautiful videos and cases. Yes, just a little comment on these. I think the most difficult task in doing these ROP vitrectomies is counseling beforehand. So counseling to the parents, because often these, like you just showed, stage 4 ones, they are you're getting good results out of these. But stage 5 ones are the real challenge. I mean, diabetic vitrectomies, we've spent 2 full days attending diabetic vitrectomies. That's a piece of cake in front of these. So most difficult cases are these stage 5 ROPs. And like one point to be noted, Sarah mentioned earlier on, that you cannot afford to have a single hole. If you get a hole in this one, that concavity changes into convexity and all the suction forces are gone, you've lost the eye.
Yes.
Oiling, gas, and this and that, that doesn't work in these ones. So you just cannot. And that is why, and you can't, in stage 5, you can't have PVD. Like the aim of vitrectomy in the older ones are PVD. You can't have PVD in these. So no need to go all the way to get PVDs done, basically to remove tractional forces, do a core vitrectomy. And the RP in these is such strong that even with that, after a couple of weeks, the retina goes back, and it's if you've done major vitrectomy and everything. So thank you very much.
Thank you very much.
That was very useful, very nice cases.
Now I'd like to invite Dr. Muhammad Amjad from Al Shifa Eye Trust. Is he here? Then we are going to have the presentation of Dr. Asma Mushtaq. She is going to tell us about ROP, a dilemma in the developing world.
Thank you, Dr. Lubna, for having me here. We've been talking about ROP since we have been working in pediatric ophthalmology department. And today I'm going to talk how the ROP is different in our part of the world, how still it is a dilemma in this part of the world, especially Pakistan. So I work in a tertiary care hospital in Lahore. And the objective of the study was to evaluate the criteria of screening for retinopathy of prematurity in developing country. To just give a background of the disease, as you all know, we're talking about ROP. So we've been screening the patients for retinopathy of prematurity in a tertiary care hospital, which is the biggest children's hospital in the country. And we have an established unit of neonatology as well in our hospital. And also it's a pediatric hospital, it's a children's hospital. So we have 23 specialities of children, various pediatric specialties working in our hospital. So we have been doing the screening for retinopathy of prematurity for last many years, and we have been collecting data for last 8 years. So now this time we try to analyze our own statistics and see how far we are good in choosing which babies to screen and what we can actually do in way forward for the screening. So this was actually a cross-sectional study which was conducted at a pediatric ophthalmology department in liaison with the neonatology department of the same hospital. And this data was from July 2018 to December 2021. It's approximately 3.5 years, but this covers the period of COVID during which our screening services and various services were shut down, or they were reduced or limited for a number for like 1.5 years also. So screening criteria which we used were the babies born up to 34 weeks of gestation and birth weight up to 2,000 grams. In addition to these, we used the babies who were admitted to the NICU of our hospital because of respiratory distress, anemia, blood transfusion, sepsis, or any other factor which resulted in the admission of a baby to neonatology center, and that was thought important by the neonatologist to be screened for retinopathy of prematurity. So those babies were also included specifically in our screening program. We have been doing in all the centers a dilated fundus examination was conducted. Most of the times we screen these patients in ophthalmology unit, And only few times we have to go to the NICU to screen the babies in special cases. Most of the time we prefer to screen the baby in our ophthalmology, either OT or a specialized place or a day dedicated which we have already designed or developed. And same dilating drops like 2.5% phenylephrine and cyclopentolate combination were used, and a dilated fundus examination was performed by a trained pediatric ophthalmologist. I'm not going to the details, but just a brief review of the results. When we screened around 426 patients completed the screening criteria, the screening of, and they were actually discharged from our screening. So we have excluded all those patients who could not complete the screening or which did not return, or those who, because we have a high mortality in the public sector hospitals, so they were also excluded. And the patients who developed any stage of ROP, either that was type 1 disease or type 2 disease, they were actually 55. And these patients so this is just a breakdown of the patients. Few had type 1 disease, and few were received ROP blind. Like ROP blind were like 18 patients out of those 55 patients. These were those who presented to us at 7 to 8 months, and we cannot actually do anything for them. Type 2 ROP was basically observed, and they were discharged, and a few of them, just a small percentage, 3 to 4%, they refused treatment. So when we analyzed the patients who developed ROP, we found them, then we tried to categorize them, that how many of them actually were less than 1500 grams and 32 weeks, and how many of them were more than between the window of 1500 grams and 2000 grams and 32 weeks to 34 weeks, so that we can analyze our screening criteria in these patients. So the analysis showed that those patients, actually out of those 55 patients, only 14 patients were the ones who were heavier than 1500 grams, or who were older than 32 grams, 32 weeks of gestation, who developed ROP. So particularly talking about these patients, when we further analyzed them, so we found that these were the patients who were actually bigger than or older than 32 weeks of gestation, or bigger than 1500 grams, but they had other risk factors such as respiratory distress, anemia, blood transfusion, or any other thing for which they had to be admitted in the neonatal ICUs. So if we can identify actually these risk factors, so we can narrow down our criteria to the criteria which is being used by UK people, like 32 weeks and 1500 grams. Because initially we started off like 10 years ago or 8 years ago, we started off with a broader criteria. But since we are getting lots of numbers of ROP babies to be screened for ROP, and this is actually increasing or way down the road when more and more awareness about ROP is getting popular. So we'll be having more and more babies. So actually I think this is our responsibility to narrow down the criteria, so that we can actually utilize our facilities, our screening facilities also, for those patients which actually need screening. And so and in addition to this, not also to miss any baby who required actually screening, or who would turn blind without screening. So my take-home message would be that this is actually, as Dr. Khurram has already mentioned, that ROP starts from neonatology, and moreover from obstetrician also. So if we have a teamwork, we can actually identify the premature babies who specially need screening. Then we can actually utilize our resources for screening of those babies who actually need screening, and not to miss anyone. And also no baby goes blind because of ROP in the coming years in this country. Thank you so very much.
Any comments?
Thank you, Dr. Asma, for this nice presentation. So just a little comment. So one of the risk factors I usually tell the neonatologist about is the fluctuation of the oxygen level.
Yes,
So a fluctuation of oxygen level is very important, as high concentration or high saturation of the oxygen.
Yes, sir.
So I usually tell the neonatologist try to keep the oxygen saturation at a stable level as much as he can.
Yes, yes, sir. So that's what we have worked in our children's hospital, because we have a calibrated team. So we have brought down to this point that actually this is the fluctuation of oxygen which is going to matter a lot, rather than what percentage they actually give. So we are working on this, and that's why I've mentioned that a liaison with the neonatologist is the bottom line of whatever we are doing.
Okay. Yes, sorry, please, you carry on. Your point, absolutely correct. And actually, she's right, we've been working on this. Last 4 or 5 years, things are changing. We used to, because of this oxygen protocol and everything, we used to get much horrendous cases a few years ago. And for the last 2-3 years, I've noted that things have changed. just because our oxygen protocols are getting better and better. But that is also only present in some of the major cities. In the peripheral areas, still there's a problem. And yeah, about there's an organization in Pakistan now, Propera. You know that you all part of the Propera, and Propera guidelines actually say 36 weeks. 35 or less. Okay, yeah, because you see, when I came back to Pakistan in 2004, I was the only one in the country doing ROP. So I started from there. And the first center I trained was Aga Khan, Karachi, and then started working in Lahore and everything. And so now you guys are on your own, doing a good job. So I used to see out of fully, when we are following the full criterias, out of all those, I have treated about 2,000 babies, okay? Out of 2,000 babies, that means 4,000 eyes. Out of 4,000 eyes, I've lost one eye. I've only lost one eye. Because none of them went to stage 3 or whatever. Sorry, stage 4, because we caught them in stage 3. And I always ask our counterparts who are in Propera from United States and everything, that you should not have any stage 4 if you're following the criteria. So, and I tell you, I've seen a 38-weeker developing ROP. Just 2 days ago, I saw a 35-weeker. A 35-weeker, 1.7 kg, no oxygen at all, vessels only at the edge of zone 1 with hemorrhages. That baby had major abdominal problems. Obviously, during pregnancy was having problems as well, and after that. So all these other, side-going things, medical problems, they have a major impact. So if some baby has other things going on, we have to change our criteria a little bit for them. This was just, I was surprised to see, what am I looking at? I was thinking before checking the baby that I'll tell the parents, okay, go home, you're fine. But no, they are stuck for a long time now. So anyway, just to tell you that this is very tricky.
Thank you, sir.
Thank you, Dr. Asma. Now I'll invite Dr. Muhammad Amjad, as his talk was missed. He is from Al Shifa Eye Trust Hospital. He recently moved back from the United Kingdom. Welcome,
Thank
Dr.
you very
Amjad,
much.
and share your experience on surgical treatment of retinopathy of prematurity.
Thank you very much. I'll be sharing the experience from my work from the UK. I was working in the Great Ormond Street where I got the Pediatric VR Fellowship. I'm sorry I'm late, so I'll try to be very quick. Surgical treatment of the ROP detachments. I'll be mainly focusing on the early stage 4A, 4B or 4B/5 endoscopic vitrectomy. But if I get a chance, I'll present some late cases as well. Before I go into the vitrectomy side, we need to understand the basics. The basics of the anatomy of the baby's eye, and understand the pathology, what is happening in terms of the tractional detachment. The adult eye is very different as compared to the baby's eye. The baby eye's posterior segment is only 20% of the adult eye. So we get a lot of challenges when we operate on these little babies. And the biggest challenge is the big lens and the chance of developing the cataract or requiring the lensectomy in these babies. In terms of the tractional component, it's multi-vectoral. So what you see in this picture is that the tractionals from the ridge to ridge or ridge to ridge or ridge to periphery or ridge to lenses. So when we are operating on these babies, the option is to do a good vitrectomy. The option is we do the lensectomy to have a good access. But if we are doing the lensectomy, we are proning these babies to develop the glaucoma. Up to 23% babies can develop the glaucoma, and definitely these babies are going to be requiring the amblyopic treatment as well. What is the other option? The other option is the lens-sparing endoscopic vitrectomy. Unfortunately, we don't have the access at the moment at Al-Shifa, but very soon, inshallah, we'll be getting this endoscope. Apart from the sparing the lens, the other benefit what we are getting is better view of the periphery with the endoscope and a better view of the multivectoral traction. So in a standard surgery, vitrectomy surgery, the surgeon's looking top down through the biome or whatever the viewing system they've got. The pathology is in the periphery. It's very difficult to see the peripheral pathology. So, but with the endoscope, we can have the access to the peripheral attractional component, and we can easily address this. And this is the picture of the fundus. A is looking top down, and the left is the same view. If you see the traction over here, you see on the endoscope it's much more obvious, and we can easily address this. And this is the theater setup we've got. This screen is showing the endoscopic view, while the middle one is the top down. And as a surgeon, we used to look at both. When we need to switch to the top view, we'll look through the microscope, or if you're doing the endoscope, it's like a laparoscopic surgery. We look up on the screen. The second benefit, what we get, is the endoscope provides along with the camera, it has got the coaxial light. And with the coaxial light, if you see the view is much superior as compared to the looking top down with the dispersed light. And because of the coaxial light, the tractional component, the vitreous, is much more easily obvious to do the vitrectomy. So a quick video of the endoscopic vitrectomy. If you see now, we are passing the endoscope through the sclerostomy. We were using the vitrectomy was 25 gauge, but the endoscope was 23 gauge to get a better view, wider view of the retina. So if you see on the top, we'll see the lens. And now we start the cutting, and we are cutting. You can see the ora serrata, you can see the pars plana. Lens is on the top. And as we proceed in the video, you'll see a lot of tractional bands, and we can easily address those tractional bands. We are not performing a full vitrectomy. We are just addressing the cause, which is the tractional band. The disease is already burned out. I think a few more seconds. You'll see at the end, when we pull the endoscope further out, you'll see these tractional bands there, just addressing these tractional bands. And you can't see these tractional bands unless you do the lensectomy. So very good approach. And once we have done the peripheral tractional vitrectomy, we have relieved the tractional component, we'll do a core vitrectomy without inducing any PVD. Primary lensectomy, our results from the from Great Ormond Street, 4A, 4B, 4B/5, the early stage 5. 51 cases. Our vitrectomy, post-vitrectomy retinal reattachment rates were much superior with a 0% lensectomy. While the other studies, if you see, there were about 30 to 50% of the lensectomy. Referral for the vitrectomy, very important. I'm not a trained pediatric ophthalmologist, but we need a good liaison with the pediatric team, and Asma was talking about the liaison with the neonatologist as well. So when to refer to the ROP for Great Ormond Street, our criteria was as early as possible. What is that early? The early is as soon as the pediatric ophthalmologist colleague will see any tractional component, and which is basically the straightening of the vessels or a vitreous hemorrhage. We know the outcome is much superior in a 4A versus 4B versus 4B5. If I've got 5 more minutes, can I go through some more cases? Okay, so the one more thing, once we've done the surgery, this was about the ROP detachment surgeries. the babies, the prem babies who haven't developed ROP or who have had the treatment, they need a lifelong follow-up. There are patients for lifelong. A couple of very big studies with a lifelong follow-up. Up to 38-40% of these babies who didn't require any surgical treatment, they were developing retinal detachment in their lifetime. So the first case, untreated ROP case once presented to me, 17 years old, as a male patient who was a 31-week ex-prem. So previously on a regular visit he was seen and having the retinopexy, but now he has developed the new detachment, had a vitrectomy, sorted. Second patient, 10 years old baby, 30 weeks ex-prem, came to us with a retinal detachment, big detachment there. When we had, we did the buccal in this baby. So after the buccal, we did the fluorescein because we could see the sclerosed vessel. So this baby never developed full vascularization, or even if they developed, it wasn't up to the periphery. So we did the laser, discharged the baby then, not the baby now, but another case, this was a treated ROP, but I don't know, only treated temporally, not nasally. This is a post-op picture. This patient had a multiple breaks at the edge of the laser where the laser was done. So this optosis post vitrectomy oil removal. Conclusion: the NICU care is improving, especially in Pakistan as well. We need the early referral. We need the early referral for the lens-sparing endoscopic vitrectomy. Number two, a regular eye examination for these babies. There's a lifelong risk. Number two is, yes, I know we are giving a lot of Avastins nowadays, or Lucentis. So please do not discharge these babies. Do have a look, and do consider doing a fluorescein at 60 weeks. And if there is ischemia, laser. These are my numbers, or email any referrals, any questions later on, please feel free. Thank you very much. Any questions?
Thank you. Lasers are a potential cause of creating retinal breaks, and we should always be careful when applying lasers to keep the power as less as possible. Thank you very much. And the next talk is also talking about...
Please. Say again? Okay.
So what's the gauge?
So I mentioned earlier, the endoscope we were using was 23 gauge. So that sclerostomy was 23 gauge.
Because you have light and all inside.
The light and the view, the field of view was much bigger. We tried the 25 gauge, but the field of view is very
narrow,
small.
and you have
So
no
we
light.
were
Because
having...
I can do the surgery with 27 gauge.
Yes.
And make indentation, so I can almost
Right.
reach every place.
Okay.
Not for the 5.
Yes.
It's closed funnel.
Yeah, 5 is
So you
can't
can do
schedule
it with light and indentation. So very
Okay.
carefully, but you can do it.
I know. In Pakistan, I don't have the access to the endoscope, so I'm doing the similar thing.
But it's a very nice approach.
It is a very
because
nice
you must cut all the anterior traction.
And one more thing is that I might have the full video. If I run the full video, that full video was only 17 minutes. So the vitrectomy is done in 17 minutes. So we are inside, outside within
Yes.
17 minutes.
From the inside to the outside, we take longer because I
Yeah.
take layer by layer.
Yeah.
To be sure that I don't touch the retina, it's longer.
Yeah.
But we can do it also.
I know.
With-
Yes, I'm switching to this unless we get the. But the endoscope was 23 gauge, so the one sclerostomy port is 23 gauge. The rest is 25. Two. Is it 3? No. 3 including the endoscope. And we sit on the temporal side.
This is lighted endoscope.
It's a lighted one, yes.
Lighted endoscope.
Yeah. So we don't use the light pipe as a separate. This, if we have to look top down, we'll use the same light as to do the core vitrectomy. Thank you very much.
I would like to invite the next speaker, Dr. Puram Chauhan, Senior Registrar at Selvangaram Hospital, and he is going to talk about lasers in retinopathy of prematurity.
Assalamu alaikum. I am Dr. Khurram. I am working as a senior registrar at Sir Gangaram Hospital, Lahore, and today my topic of presentation is laser application in retinopathy of prematurity. As we all know, anti-VEGF injections have therapeutic potential, but laser photoablation is a crucial tool both for first-line ROP treatment as well as for recurrences after the anti-VEGFs. So, and in the past few decades, laser has completely replaced the cryotherapy because it is less invasive, less traumatic, causes less discomfort to the infant, and it has fewer post-operative complications as well as it induces less myopia. Thank you. In a study done, a single dose of 0.312 milligram bevacizumab was effective in to induce regression in most of the type 1 ROPs, but not in aggressive posterior ROP. And their FFA was done, and they describe vascular abnormalities and the which causes importance of which warrants further investigation. So in another study was done, it was detected that complete retinovascularization was not observed in any of the cases which were given second dose of anti-VEGF due to recurrence, and their FFA showed vascular arrest and avascularity as well as leakage. So early intervention with laser photocoagulation enables us the prevention of possible blindness in these kids. So these are the brief indications of laser in ROP. Basically, we can do it as a first-line treatment in type 1 ROP, like zone 1, stage 1 to 3 ROP with plus disease, zone 1, stage 3 ROP without plus disease, zone 2, stage 2 or 3 ROP with plus disease. Especially, it has a role in aggressive posterior ROP and in recurrent ROPs after intravitreal anti-VEGF injections. And aggressive ROP is treated within the 24 to 48 hours, whereas type 1 ROP we can delay slightly for 48 to 72 hours. Before applying the laser or treating the ROP, counseling of the parents is very important. We should brief the parents about the nature of the disease and about the natural course of the disease. In Pakistan, we have to say that if the treatment is not done, their child will get blind. So we have counseling of the parents is very important, especially about we have to stress about the follow-ups, because it has a recurrence and the patient has to have multiple follow-ups. So parents should be advised that they should have multiple follow-ups and regular follow-ups every 6 months or 1 year, so there can be retinal complications and development of myopia later on or development of strabismus. Before applying the lasers, we have to dilate the pupil. Dilation is done with 1% tropicamide and 2.5% phenylephrine. Drop is used every 10 minutes 2 times, and it is done 30 minutes before the procedure. If the pupil is not dilating, we can use the mild steroids or cyclopentolate, but or we can take the help of anti-VEGFs to decrease the intensity of the new vascularization and plus disease. Then it can get easily dilated and we can assess the peripheral retina easily. Laser is done in clean temperature controlled environment, and child should be well wrapped to prevent the hypothermia, as well as child pulse oximeter should be attached, and resuscitation facility should be available to manage the apnea if it occurs, and it should be preferably done in the presence of anesthetist and neonatologist. The area before applying the laser or placing the child in the theater, we should clear the area head area around the table, and an assistant wearing protective glasses should hold the baby and keep the cornea wet. Laser can be applied in topical anesthesia as well as in general anesthesia, but topical anesthesia is preferred and it can be easily, a laser can be easily applied if baby is less than 1.8 kg of weight, and it is more easy for the baby and anesthesiologist and neonatologist, but slightly difficult or tiresome for the surgeon. But its safety is more in case of topical anesthesia. And child should not receive milk 1 hour before the procedure. And if the child is if weight is greater than 1.8 kg, then we can have general anesthesia, but it all depends on anesthetologist and a neonatologist with the consent of anesthetist and neonatologist. For managing pain, proparacaine topical anesthesia is used, and we can use 5% dextrose analgesia. What we can do is we take the sterilized gauze piece and dip it in 5% dextrose, and we allow the baby to suck on this sterilized gauze piece. This comforts the baby and calm down the baby, and we can easily apply the laser. Power of the laser varies between 100 to 400 millivolt depending on the pigment epithelium in the retina, but usually we start with 100 milliwatt, and as long as the grayish white burn is achieved, and we should always avoid white or chalky burns. Here are the these are the ideal burns for applying laser in children. Duration should be 200 millisecond, which can be increased to 300 millisecond depending on the media clarity and the burn color. Here is the picture. First of all, we should take test shots before applying the laser to the whole retina, because these white burns are showing the excess power, and this should be avoided, whereas these white grayish burns are ideal, and they are adequate for ablation of the retina. For the new beginners or learners, they can start slow from 300 to 500 millisecond interval, but it can go as fast as 200 to 300 millisecond. Basically, it should be not as fast as that the effect of the laser is not there, or as slow as there when the next shot is done, the eye of the position of the eye is changed, and so that spot diameter can be adjusted as necessary for the proper treatment, and maximum size of 400 micron may be used. It helps in the covering the entire retina, as well as shorter the duration of application of the laser. An average of 1000 to 2000 shots half width apart should be placed on the entire avascular retina from the ridge up to the ora serrata. Ora serrata should be identified with the help of indenter, and it should be all the areas is lased so that no viable area is left between the laser, and we should avoid the ridge because applying laser on the ridge can cause hemorrhage. And then further directions. So during laser treatment may be applied first to the one eye for 10 minutes, and then we can give rest to that eye, and 10 minutes for another eye. Basically, if we can do that, surgeon can take the advantage of his position. When he is on the right side, he can laser the nasal retina of the right side, whereas temporal retina of the left eye, and 10 minutes each. Then if he shifts to the left side, then and apply the laser on the nasal retina of the left eye, whereas temporal retina of the right eye, so that eye can get rest, and as well as patient is also comfortable, and it prevents the exposure of corneal exposure, and patient is here is the patient being laced in our theater. This is a beautiful shot just taken at the split second, and it is depicting beautifully the position of surgeon and the laser and the assistant wearing glasses and holding the baby. can stabilize the eye with the help of wire vectors or squint hook, whichever suits you. They can also use for indentation, whereas during scleral indentation we should take care that the area just posterior to the indentation is sometimes skipped, which is shown as a red arrow. So we should try to never skip these areas and take special care to apply the ablate the whole of the retina so that no viable tissue is left. Managing the APROP is quite challenging. It is suggested that APROP laser can be done in 2 steps. In the first step, avascular area up to the flat neovascular front is laced. Here is the avascular area. This is the flat neovascular front. Laser is applied, and when this neovascular front is regressed, then second session the area is also ablated, as the area beneath these fronts continue to remain source of VEGF and causes the reappearance of the disease. And this is a FFA done in the APROP patient. Here is the ridge, and this is the avascular area, whereas this is the new vascular area, which is showing the capillary dropouts, AV formation, as well as leakage. So while applying the laser, we should apply laser on this avascular area, as well as 2 to 3 shots should be applied posterior to the ridge to cover these areas. Complication of lasers include burn in the cornea, iris, retinal and vitreous hemorrhage, development of cataracts, glaucoma, anterior segment ischemia may follow, has been reported after the laser, and development of myopia in the later stage. It is estimated that 1.5 diopter plus minus half diopter diopter of myopia can occur after applying 1000 shots. In conclusion, laser ablation has been the gold standard for the treatment of RP. It will remain as a crucial tool both for the first line ROP and recurrences after intravitreal injection, and special considerations should be taken in AP-ROP cases, acute phase ROP, long-term stability, and potential systemic effects. Thank you.
Thank you, Dr. Khurram. Invite Dr. Khurram Mirza, the teacher of ROP since 2004, the teacher of us all, who taught us how to screen, how to treat for ROP.
Please.
Injection for local anesthesia in a child, have you ever tried that? Because if you do a topical, then they usually move the eye during doing the laser. If we do like a peripulbar injection, can it be done?
Before I answer that, I'll ask Dr. Khurram, has he left? Oh, so all these lasers that you've done in topical anesthesia, you must have done a little audit on those. So recurrence rate, did you notice any recurrence rate? How many did you have to go in again for? And who developed some other new vascularization after your laser? Oh,
yeah. Sir, luckily we didn't get any AP-ROP. In the rest of the ROPs in which they are not responding to the injections, then when the laser is applied, there is no recurrence. But in AP-ROP, there was one case in which we have to apply the injection and laser twice, because there was a recurrence of the laser, recurrence of the disease.
Okay, so well, that's still pretty good results, considering you're doing topicals, and because what I have seen that a lot of babies who've done under topical anesthesia, sometimes they come to me to be checked again, and I see lots of areas, untreated areas. So chances, that's why they say the baby has to be followed up for life, because you can have problems later on. But that's my argument. I'll show you the figures as well in my presentation, that we have to do all the things so that we can do proper treatment. And with proper treatment, your recurrence rate after laser can be as little as 0.002%, so almost zero. Okay, so and like Dr. Sarfraz just mentioned, it can be done under local anesthesia, yeah. And so in my personal experience, I do all of them under general anesthesia. It all depends on what facilities do you have. I mean, not doing it at all because you don't anesthetist is not happy. It's better to do under topical anesthesia. So many babies to be looked after. So that's the thing. So the choices are there, and so the only ones I've done under just topical anesthesia are where we knew beforehand. You know, this was before the anti-VEGFs. We knew beforehand, and that we were doing a posterior disease. We wanted to leave some area and see how things go. So we knew beforehand we may have to top it up if there are new vascularizations. So out of 1,000, I think there were 2 or 3. That's all. So that's the thing. So now, not a topic of my choice, but this was given to me. So anti-VEGFs in ROP, because I have been a fan of lasers, but with time, slowly, there are 2 things happening, and those 2 things which are happening are that younger and younger babies are being saved. So that means more posterior disease.
Yes.
On the other hand, the oxygen protocols are getting better, so the previous 30-weeker or a 29-weeker, they are doing well actually. So they are not developing so much ROP as they used to. So, but more posterior disease, because now we often see 25-weeker a lot. So that's why, and we can't laser them to start with. So just a little, I won't go in details of these pathogenesis and all that. We all know that there's this VEGF level. Initially, the VEGF level goes down, and because the baby is on oxygen. And once the oxygen is stopped, then the VEGF level goes up, and that leads to vascular proliferation. And we also know that by 36 weeks, then usually the average retina gets vascularized, but the temporal one gets vascularized by 40 weeks. And so this just sudden rise in VEGF will cause this vascularization, and so our treatment, whatever the treatment is, has to be just focused on that new vascularization and VEGF. So it started with cryo, you know, we are talking about lasers, and this whole thing started with cryo. So cryo ROP study was done 1988, and it was only after that that it found out that, okay, the results have improved. Not so much, I mean 40% improvement in structure and 30% improvement in the vision thing, but still it was a lot because every baby was going blind before that. So that's where the screening started. But cryo obviously had its problems. Cryo, there are some short-term problems about cornea and inflammation and cataract formation and all that. Then there were long-term problems because of cryo. So obviously cryo didn't go on for very long. So then came lasers. Laser, like Khurram Chauhan just mentioned, you know, they can cause myopia. They will cause myopia, and for it's 1.14 in every 1,000 burns. So if you're often if you require, it's a mid peripheral disease. You're saying 2,000. I sometimes have to do 4,000. So I think because I believe I don't believe it's been taught everywhere that these should be confluent burns. There should not be any skip areas in there because they will cause recurrence. So I require, usually, it's a very mild disease, I require 2,000, otherwise more. So myopia can occur, as opposed to, obviously, if we give anti-VEGFs, it's much less myopia, 1.5 milligram, diopters, as opposed to 8.5. And that's for posterior disease. So for posterior disease, obviously, we should go for anti-VEGFs. Now, one certain definite indication would be APROP. APROP you cannot control with laser. You can, but then you'll be destroying half the macula. So if you will, we used to do that before the anti-VEGFs came in. We just used to have little macula left there, and everything else is gone, and the eyes are stable. But to avoid that, as we know, bevacizumab came in 2004 for colorectal cancer and all that, but then in vasoproliferative eye diseases, they started in 2005. We started here a year later. I still remember late Ali Haider and myself, we went to Shaukat Khanum and we sat on with the panel to start giving Avastins here in Pakistan. So originally, so it was only laser. Then for posterior disease, we started giving these. Sorry, excuse me. So for anti-VEGFs, this beat ROP came in, and with that we found out that there was they did a comparison between the anti-VEGFs and the lasers. And there were advantages because after anti-VEGF, you could still see vessels growing and retina would mature. With the laser, you will just put a barrier and that's it. And then there was this about the dose. The dose originally they said was half of the adult dose, but later on in the recent studies, they're slightly increasing the dose. Now, there are situations. What are the main indications for anti-VEGF injections? You know, babies not fit for laser for a lot of reasons. I've had a few of them, so we had to give anti-VEGFs, even though the laser would have been the best choice. But it buys you time. It gives you another month to 6 weeks, and by then retina is more mature, baby is more mature, and you can do a proper laser later on. Or if the disease is too posterior, especially if it is APROP, and or the view is blocked because there are so many hemorrhages and you will be leaving a lot of skip areas, so it's best to go for that. And or somehow, if your first treatment, it's an aggressive disease and still causing some, you can do that. And lastly, if you have to go for, you know, those vitrectomies where there are still very active vessels inside, then you can give anti-VEGF beforehand and then do the surgery. So these are the ones. A lot of controversy going on about these anti-VEGFs all over the world, just to show, you know, this new vascularizations and then after anti-VEGF. Within, if you see the baby in 3 days time, you won't be able to recognize the eye because all the plus disease is usually gone by 3rd day, and if there are anterior vessels, they are also gone in 3 to 4 days. And so everything settles down, so you get more time. So such vessels, you can't do laser through these vessels. If you just try and do lasers through these vessels, even if you can, the lens is going to, area around the lens is going to absorb the laser in a lot of places, and you will end up having cataract, and the view will be difficult anyway. Now, so APROP is the main thing. It is getting common now because younger babies are being saved now. It is different than the usual posterior zone 1 and 2 disease. In the usual ROP stage 3, in these, the vessels are, if you get stage 3, the vessels are raised and all. But in APROP, they're often flat, and sometimes there is no ridge. That is the misleading point. You know, you have to see if there's a mesh, flat mesh all around the posterior pole, that's APROP. And that is different. It will be very aggressive. It will require more treatment, and so that's the main thing, is that the new vessels are often very flat. The other thing is that in the absence of a ridge, there's still shunting going on, and that shunting is going on throughout the posterior pole, and so one should recognize them, because if you don't recognize them, you may give them maybe 2 weeks to see, and they'll just get worse in 2 to 3 days. So, and often I come across few babies where I advise laser, but sometimes they were not, they wanted to get a second opinion, and they got a second opinion, and the other person did not realize that this is APROP and said, okay, you can wait. So 1 month down the line, they come with a lot of tractions and everything inside. So that's a pity, you know, that's unfortunate. Now, the thing is with, they have compared again with laser, the anti-VEGFs, they say there's higher incidence of recurrence rate with anti-VEGFs, and a lot of follow-ups have to be done, like you mentioned, 60 to 70 to 80 weeks, you know, because you have to decide, you know, the final treatment, in my opinion, you can argue with that, should be laser, if at all if at all needed and something. So you should, even if you have to do anti-VEGFs, be prepared that it is going to become active again. As soon as it does that, then you should be ready to do laser. And because laser is the final cure. After the laser, if the laser is proper, then nothing can go wrong, things will be under control. But with this, even with this, there can be cure. We've seen babies who did not require laser at all, and we kept on waiting for the neovascularization to come back again. That never happened, and they completed till till full zone 3. So once that happens, then you're okay. So, and then there are side effects of the lasers as well, complications, endophthalmitis, detachments, and all those. And I see a lot of lens damage. A lot of people are giving anti-VEGFs. We'll talk about that in a second. And then the main issue with the anti-VEGF, this has been going on in America and Canada a lot. There's been a lot of concern about neurodevelopmental delays with anti-VEGFs. As most of the time, bevacizumab has been used in these, and all the studies are on that one. I won't go in all, sorry. We won't go into all the details, but as you can see, that as opposed to laser, 78% babies develop neurodevelopmental delays, as opposed to 56, because these babies they do get neurodevelopmental delays anyway, even if they don't get ROP. So, but the difference is significant, and severe delays in the last line, 52% as opposed to 29. So there's something going on, and that's why, because in Canada they started doing just injections in some centers and no laser. So that meant 3, 4, 5 injections in total. And so this came up, and then they stopped doing that, because as we know that bevacizumab is found in the circulation, peak is found till 2 weeks. So that's just the peak. After that, 2-3 weeks it takes to wash out. So it's there for over a month. And similarly, the VEGF level goes down. When the VEGF level goes down, a lot of other organs are affected as well. And so because, you know, lungs, kidneys, brain, and all those things, they require VEGF levels of certain level. So their developmental delay can happen. The difference, again, we just mentioned that laser is a cure. Once that is done, nothing can happen after that. Avastin we have given, and after that we have to wait for those to complete. And until that happens, we have to keep looking at them. But they do buy time. Bevacizumab has been used more, but I only use ranibizumab. I've only given one Avastin, I think. But economical factors are there, and if somebody can't afford it, it's better than nothing. But that's what we just saw. That was bevacizumab 1 month in the circulation, as opposed to maybe around 2 days of ranibizumab. So I find it to be very gentler and safer, so I use that. And injections, again, they're slightly different than the adult ones. Only 1.5 millimeter from the limbus rather than 3.5 millimeters. And needle, the direction of needle, I just did a quick one here. You know, in the adults, when we do intravitreals, the idea is to have the needle pointing towards the optic nerve. Do not do that in this one, because the lens is bigger in proportion to the eye, and so Ideal is to hold the eye with a forceps, go straight down. Injections we do under topical anesthesia, but we hold the eye, we go in straight, and best is for somebody else to inject. And very important thing here is, I've seen a lot of babies coming in, having injections done elsewhere, and with retinal holes, small tears with hemorrhages around, and that put me in trouble, often. What should I do? I mean, sometimes there's fluid collection there, I have to do unnecessary laser on that, which I do under topical just to cover that area, because I don't want to treat the full ROP laser. So go straight down, ask somebody to gently, the intravitreals should be given very gently, otherwise they can cause hole. Even if you don't touch it with needle, just the jet of the injection. Now, a little bit left now only. They're quite safe, and several studies on anti-VEGF, they say that they are equally good as laser treatment. But I've gone through all those studies, they all have a lot of flaw. Okay, the main thing is, even with people in Albert Einstein Institute, Umar Mia, who is part of our Propera here, he comes from United States. He is the one who has played a major role in developing ROP services here in Pakistan. But I have my arguments with that. It's the same thing that, something is wrong in their laser pattern, because they are showing 20% recurrence rate. All these studies, 20 to 25% recurrence rate. That should not happen. So something is wrong with the laser pattern. So I mean, if that is wrong, the whole studies is of flaws. So so the results of that are, no matter what the starting point is, laser treatment should be the final option. It does not have to be the first option, but it should be kept in mind that that is the mainstay of treatment. So in my practice, balance has to be kept, in practice. My recurrence rate of laser, not those who come to me at 5 months of age with half 4, so I'm only saying, including the patients which we screen according to protocol. We have a very, very busy hospital for these babies, full, huge neonatal wards and all that at Hamid Latif Hospital. So I've had to go in to do laser, and that was also planned laser because it was posterior disease, 2 out of 1,000. That is the average. So anti-VEGF alone settling that. Now, since I've started using slightly bigger dose, and plus I think it has to do with better oxygen protocol originally, that there are some kids that I've been waiting and they just completed after 1 injection. So that's there, and majority required that. Now, out of that study, I'll just give you an example of just one case. There were millions of cases in those studies. These are all Western studies. And so a baby was born at 24 weeks. At 32 weeks, developed stage 3 in both eyes with plus disease, was given bevacizumab. Then at 39 weeks, they had recurrence, given bevacizumab. 57 weeks, another recurrence, bevacizumab. Then laser treatment was done at 67 weeks. And what happened? The right eye progressed to stage 4A, left eye developed pre-retinal hemorrhages and whatever. So that should not have happened. If we had, this baby should have received laser after 1 injection. If that happened, the baby would have been fine. So that's why I keep saying that where the protocol is good, no baby should go on stage 4. So for type 1, I do, for a recurrence, I do laser. Or if the recurrence is very posterior, then we have to repeat anti-VEGF. I usually don't want to do laser unless the vessels are at least till. I divide my zone 2 into 3. Whenever I'm looking at my babies, it's inner zone 2, mid zone 2, or outer zone 2. So at least by outer zone, when they're touching outer zone 2, only then I do laser. we've tried ILIA as well as anti-VEGF on because I was given a condition that this baby cannot have GA for a very long time, do this, so we tried ILIA. And that day it was, with those babies, it was proven that the effect of ILIA remained in there for more than 2 months, did not develop recurrence, whereas the other two are usually 4 to 6 weeks. Our observation is oxygen protocol has improved a lot here in our hospital, making overall the disease process less aggressive. Smaller babies are surviving, so posterior disease is also coming and it's becoming more common. A lot of babies who are referred to me from outside, well, in that context, I must thank this gentleman here, Dr. Sarfraz, because I think in the Faisalabad region, he's the site saver there because he's looking after all those. I'm not referring to you. There's so many others I've received lately I think they're giving the injections too early. Now one has to be very careful because I'm now noticing that all those babies, I have to follow them up much longer and the vessels are not growing at all. And I can't figure out the cause, but I just noted in all those that they were getting the injections by second week or something, so people are being too trigger happy. And I wonder if that has any effect on the normal vasculature. Can't prove it, but just we are collecting data on that. So that's the thing. I'll just go quickly. Treatment should be done according to proper indications, and pending further evidence, lasers should remain the first line of treatment. Anti-VEGF should be given when laser treatment is not feasible due to any reason, whether it's posterior disease or view problem. And proper training, people should get proper training before giving these injections, and then everything will become safe. Thank you very much.
Thank you very much, Dr. Khurram. So would you like to have comments?
On one side, I've seen the vessel just reaching very close to the zone 3 or even in the zone 3. And on the other, in the other eye, it was just in zone 1 and almost stay 2 or 3.
Yeah, out of thousands, I've seen only
Yes,
2.
one. Yeah, I've seen
only
only one,
seen
yeah.
2 with disparity. The other thing I wanted to mention, hemoglobin. Please keep an eye on the hemoglobin of the baby. Okay, we are doing a full study, full series, all these patients, we are looking back at them because I started getting twins. And out of those twins, one had it, one didn't have it. Oxygen protocol and everything was the same. So I looked at the notes and I found out that the hemoglobin was very low in that one. So now the ones with low hemoglobin, they do worse, or they take longer and they a lot more treatment and everything as compared to when the hemoglobin is okay. And so we always ask them now about how packed cells given and all those. The other thing I'm noting is gamma globulins. Babies are getting gamma globulins as well, and those babies are not doing too well. But obviously, it's probably essential for their life, but it's just to be careful when these things are there. You can add them in your questions when you're talking to the parents.
Could there be any congenital anomaly which is leading to the less oxygenation or less blood going to the one eye, where you see more the advanced stage of ROP than the other eye? Would it be one of the cause that
I doubt because sooner or later eventually they catch up, and we sometimes have to give uniocular anti-VEGF, but eventually it catches up. I don't have an answer to that, to be honest. Okay, why one?
In zone 2 are like that. So when do you go for laser in such patient? We don't have the facility of handheld FFE for these patients. So
you see, I've had few patients where only I also divide my patients to protemporal and frontemporal quadrants, and one eye totally complete, the other eye supratemporal quadrant totally complete, infratemporal quadrant, outer zone 2, sharp demarcation line, no new vessels. Okay, I said I'll just observe. We kept on observing for months and nothing happened. These are the ones who either you keep observing for 2 years and maybe they'll complete. Then I told them that we'll do a bit of laser and finish it. So that's when I do the laser.
Just follow.
No, eventually, after maybe 6 months, you have to do laser. Okay, otherwise the whole family will get tired.
Yeah.
Yeah. Thank you. Ji.
Sometimes it's almost impossible to apply lasers. So
When-
what's the
when the-
hack? They do not respond to
This is
phenylephrine.
this is the 35 weeker one I just mentioned earlier on, that a 35 weeker, a nephew of our best neonatologist, and no oxygen at all, full of hemorrhages in the eye, zone 1, and with a lot of abdominal problems. Now, that baby, the pupils were not good. The pupils did. So when the pupils are not good, be prepared that this child has problem inside. So it will give you some view to figure out what's going on. That's the baby for anti-VEGF. And with the anti-VEGF next week, the pupil will get bigger.
Thank you, Dr. Khurram. Now I'm going to invite my mentor, Professor Muhammad Moeen, for his speech on ROP Task Force and opportunities ahead.
Thank you very much. Sorry, I was stuck in some administrative issues, so I couldn't join the sessions. So my talk is on ROP National Task Force and opportunities ahead. As you know, all of you are involved. I think most of you are, kitne log kara rahe hain, screening kar rahe hain, how many people are baithe sare. So all of you, so that is good. So finally, we've got a workforce and capacity building has been built over years, so which is good. So the next thing is to come up with a plan which can be implemented by the government and public sector hospitals, and that can be a national plan which can be collaborated with the armed forces and with the private medical colleges and private hospitals, so that babies can get the right to be screened and to be examined like babies get hearing tests after they are born. So ROP is one of the things which in some countries it is a legislation that if a baby does not get ROP screening after a certain time, he is the doctor, the pediatrician is liable for that for non-referral to the ophthalmologist, and the ophthalmologist in US probably the lawsuits for children run up to the age of 18 to 20 years. So even if the child goes and he is engaged at that time, at an older age, they can come back and say, well, this did not happen and that person is responsible. So we need to come up with a plan so that over time, because ROP is increasing in our country, so we recently, so in order to tackle that, we initially started our work with ProPara in 2013, and Dr. Umar, he comes here, and we were involved, Dr. Khurram was there, and JPMC Arifa was there, and Dr. Surat were there in Karachi, and we started off as a small group, and now, mashallah, we've engaged more and more people, and it is, I'll discuss the task force which we've developed over time. I think we were just nidus for starting it, probably people had their own initiative as well, and I think we're grateful that they join us and help the thing to grow. So the most important thing is increasing prematurity and low birth weight. And then as Dr. Khurram was pointing out, low hyperoxia, the oxygen, if the neonatal care is responsible for the development of ROP. So I was there in the World ROP conference last 2 months back. And there, the people from international countries, they say like from the West, US and Canada, they say we don't see that much of ROP which is treatable because our neonatology care is becoming so good that patients don't develop those problems. Sepsis, babies who are sick, who have got more problem, probably immunoglobulin babies, they're probably more sick. So those babies are getting the shots, and that is the reason poor weight gain And lack of antenatal steroid administration. Those are the factors which are very important. So it's just not oxygen. So it's very rightly pointed out by Dr. Khurram that you have to think elsewhere what is happening with the child, how sick he is, and what things he's undergoing. So our goal for the task force are to reduce avoidable blindness and visual impairment for ROP, building on the lessons to learn. So in 2019, we had our national ROP conference. Dr. Claire Gilbert was here, and Dr. Shahid Hussain, the neonatologist, was here. And recently, we also did sort of a group meeting. We made a Lahore City Network we had a meeting, and there we had neonatologists and ophthalmologists from across Lahore come in and sit together and think what we can do for the future and what problems they're facing and how we can resolve those issues. So the comprehensive strategies are preventing preterm birth, high quality neonatal care, screening and treatment, and long-term follow-up to detect, manage the ocular complications, and also rehabilitation of the babies. So urgent need to increase the awareness about ROP is not. So we need to do advocacy for the parents. Then we have the policy makers, the health professional, hospital management, and I already discussed parents and community. That is more important. What we found is usually the parents who have their children involved in ROP, probably those are the best people who will advocate for you. We usually keep a yearly ROP day. Lubna sort of arranges that on the World Sight Day in October, and we have all the babies who have been treated with ROP. They come and attend that with their parents, and we celebrate that day with them that the sight was saved and they can move forward in their life. So a significant cause of blindness, so death of premature 2000, so there are 15 million babies who are born premature each year, and 60% delivery in sub-Saharan desert. Premature Pakistan, and about 860 premature births are recorded each year in Pakistan, and prevalence of premature births in Pakistan is 21.64%. So recently, when we went to the ROP international meeting, they made an ROP, World ROP Council. So I was representing Pakistan, so included me in that. So that is another forum through which we can sort of project or give the forum for world ROP, where they make their classifications of ROP and the treatment strategies of ROP. We can give our input and sort of what guidelines we use that can be incorporated in that thing. So we've made initial recommendations for ROP screening that was published as ROP screening protocols a few years ago. And those are the initial steps, but we still need to sit down with the ophthalmologist and with the neonatologist to come up with more strategic and comprehensive guidelines, which is a consensus which is mostly needed. So recently we have a publication in BMJ Ophthalmology, in Pediatric Ophthalmology, in where we looked at babies who were coming in blind, presenting blind to us, and we tried to find out to describe the ocular feature and characteristic of young babies presenting with advanced ROP, and we had about retrospective study of 5A and 5B or 4A and 4B ROP at LGH from 2007 to 2019. So over 2 years, these are the babies which we saw, and we had 51 children presented at mean age of 9.7 months, and the mean gestational age was 28.84 weeks, and mean birth weight was 1229 grams, and 4 children had birth weight of greater than 31 weeks. I'll discuss that thing later. So important thing in this graph is that the gestational age which you see, normally the international screening criteria will be at 31 weeks and 1.5 kg. So if we use these criteria, say 1, 2, 3, 4, 5, 6 babies would not have been screened if we were using those criteria, because we would say these babies are okay, don't screen them. So that is why we need to encourage, that's why we came up with initial screening guideline by consultation with international expert Claire Gilbert, and they told us that internationally in low-income countries, these are the criteria, 35 weeks and 2 kg, and we've been screening on those criteria. Obviously, you need to screen more babies when you're using that criteria, but you can find your own criteria which is the most appropriate, and if you think you can make this graph of all the babies you're doing, and if your graph does not have babies on this side, you can shift your criteria to the other side. So that's fine, but as long as you don't miss babies, that is the main thing which we need to see. So we had stage 5B patients, 5A, and then the mean, and so this is the cicatricial group B disease. So these are the number of patients we had. So you can see, I'm not going to go through all of them, but the important thing was, does ROP only happen in big cities? We found out the number of babies who were coming out from Lahore and less than, so this is 100 kilometers population of the city. So this is 200 to 250. So there are babies coming in from different districts which were also included in the blind baby. So it's just not Lahore who are getting babies with ROP. People in Gujranwala, Sahiwal, Okada, other places, they are also getting ROP, and they get referred to us because they say that that is the only treatment at that time available. So they can go and probably Dr. Khurram sees more of them. If you collaborate more of the data, Dr. Amir Rawan was saying, they see a lot of those blind babies, and Dr. Haroon Tayyib was saying, and Dr. Arfa and Dr. Saima, they also see these babies. Probably if we combine all of them, so probably over a year, I think we'll be seeing around 100 or 200 babies who are going blind every year in Pakistan. If we extrapolate the data in that sense, so that is a big number to have that many babies going blind, and we're just waiting, sitting on a volcano which is going to erupt at any time in that sense. So the conclusion was the third epidemic due to ROP has arrived in Pakistan, and babies are going blind even in smaller cities, and so we need to use a gestational age of 35 weeks and 2,000 grams. The rationale of publishing that paper in international literature was to give sort of a supporting document to people who want to start a screening program in Pakistan, that this is the rationale for using these criteria. If you don't agree with that, please do find your own criteria and work accordingly. But I think this is a reasonable criteria which we all should be using. So what's happening in the developing world? So ROP is pretty high. So you can see in this graph, and then going forward, number of blind children per million population by cause and level of development, 1.4 million blind children in the world, and you can see there's a high incidence due to ROP. So where are preterms both most common? So you can see the rate is higher, less than 10%, 15% or more. So Pakistan would be coming in these areas. So this is 210. So Pakistan is number 4. This is, I think, the population where the children are being born. So, and this is the incidence, ROP blindness, which is showing up. And you can see Pakistan falls in this area, which would be high risk of ROP because the neonatal survival rate has decreased. So more babies were being born earlier are saved. As Dr. Khurram was saying, 24 weekers are being saved. So that in private, in government hospital, at least 28 weekers are being saved. So those are the babies who are at more risk of ROP. So Pakistan is close to that area where India was in 2005. So this is a time when more ROP is going to be seen, especially in lower income countries. So this is the percentage of blindness due to ROP. So you can see it was 60% in Argentina in early 2000s. And this is the characteristic of baby seen with the severe ROP. So you can see all of the babies fall near to that 31 weeks and 1200 grams, but ours are falling on the other side. And similarly characteristic of baby in severe and low income countries. So you can see babies are going towards the 35-week area in these countries. So this is our graph, which I already showed. What is happening in Pakistan, awareness in Pakistan. In 2010, that was a study. Then Aga Khan, Dr. Salat came up with a study of less than 1500 grams and less than 32 weeks. Out of them, 32% developed any ROP and 20% stage 3 or worse. So I'll just go quickly. This is Aga Khan. And then this is Aga Khan. Hamid Latif, Dr. Khurram published his paper in 2015. And his rate was with less than 22,000 gram and less than 37 weeks, it was 24%. Stage 3 or worse, 7.7%. So this is the same thing, which is, so Propera I already explained to you. This was created in 2015. This is Graham Quinn in US and Claire Gilbert from UK. Then this is the Propera network. So I've gone through that so many times. I'll just quickly flip this over. So this we've gone. So 5% of all premature babies born 35 weeks or less can go blind. So not all babies will go blind because of ROP. So there are 6 million births, so 20% prematurity, 10% less than 35 weeks with 50% survival of the babies. So it comes out to be 5% babies without any treatment. So the social burden is 12 to 15,000 blind babies can be being born. This is an extrapolation of what can be happening in Pakistan. The social burden, if one baby is, so this was something we calculated with a rehabilitation person. He said probably 6 million for a lifeline support of one baby. So this is the social burden. This is coming here. So professional. So the ethical and moral and financial liabilities I discussed earlier. So these are the people involved. I think Propera now, or probably ROP centers, which are now is LGH, Mayo Hospital, Children's Hospital, Gangaram, Jinnah Hospital, FMH, Hamid Latif, JPMC in Karachi, LRBT, Aga Khan, Liaquat National, Al Shifa Trust, Shifa International, Khyber Teaching in Peshawar, Nishtar in Multan, Faisalabad, Allied Hospital. I think district, you're in district hospital? You're with Allied or you're Dr. Sarfraz? But you are now doing private. So it's scattered. Anybody missing in this slide? The centers are all of you included in this. So that's good. So those are the centers, which is good. This is the ROP, Lahore ROP network. So I think they had a similar meeting in Karachi, Arafah. So what we want now is the next step forward is making regional or city-wide networks so they can collaborate together. If you have 1 week, sort of once a month meeting, you can present a case on ROP and difficulty problems which you encountered. That can get you together as a network and probably get, if babies are difficult, they are referred, they can go to another center, and if there are some facilities which are available or down at one center, you can obviously refer them to another center. So ROP coordinator, I think most of you know the importance of the ROP coordinator. Screening rates have increased remarkably because of that, and post-diagnosis sort of screening rates for follow-ups increased to 81%. So this is the level of prevention. So recommendations for ROP. I think there are a lot of recommendations where the OSP task force can do, but I think the most important recommendation is to do a situational analysis first. For that, we'll need help from everybody. So we want to identify each center and see they are seeing babies, what is the burden of their disease, and what is the characteristic of facilities in the pediatric department. So we need to collaborate with the pediatric department. Once we have the situation analysis, we can sort of give it to the National Committee of Eye Health, to the government of Pakistan, and then from there they can define the resources which you need for human resource development, for purchase of equipment, for for training, for infrastructure development, and from there we can go forward. And the next would be, once you develop situational analysis, then you come up with developing your guidelines to which everybody agrees, creating a national database for collection of data, sharing of data, and sort of improving structure. So I think I'll just leave it at that. So those are the thoughts, and if there are any questions, I'll be ready to answer. Thank you.
So we are very thankful to your efforts, sir, to establish these ROP services in the country to encourage prevention of blindness due to retinopathy of prematurity. The next talk is by Dr. Saima Amin. She is going to enlighten us with the recent changes in international classification of ROP launched in July 2021.
Thank you, Dr. Lubna. I'm so grateful to be sharing the podium with such great people. We have here the pioneers. I remember when we were doing our residency and I said I was confused about ROP, and my senior said, these are just 2 pages of CANSI, go through it and you'll be good to go to the exam. So, and now we are having sessions. So I'm going to quickly just walk you through the new classification. There's just a few terms that have been included, and I think it's very important to know. Why there was need to revise this, the last classification that we had was in 2005, and the reason that had to be revised was mainly because of the introduction of anti-VEGF, and because the retina behaves very differently with anti-VEGF as compared to laser. So, and then a few terms were very subjective, like pre, plus, and plus disease. That was another reason. And of course, now it has been recognized that the pattern of ROP in the developing and the developed world is slightly different. So the term, we all know about the zones. So now there's a new term which is called posterior zone 2, and that describes two disc diameters beyond zone 1 towards zone 2. And the reason why this zone is very important is because it's not too anterior and it's not too posterior, and most of the ROP that we find is in the posterior zone 2. So this would be posterior zone 2, where you see that, so the green arrows point zone 1, and that is where it will end, and then 2 disc diameters beyond, and this will roughly be posterior zone 2. The notch describes incursion of 1 or 2 clock hours towards the posterior pole. And when this is present, then the zone, or when you would classify ROP, you classify according to the most posterior side that is involved. So in this, it will probably be a posterior zone 2 ROP, secondary to incursion. So you can say secondary to a notch. So you know that the rest of the retina has been vascularized more anteriorly, while the notch is there. So some of the retina is not so vascularized so much anteriorly. Then the term pre-plus disease was before labeled in the 2005 criteria that there's just arteriolar and venous tortuosity and dilatation, not fulfilling the criteria of plus disease. But now it's been further defined, and now these are the sample pictures that they have put up in the new classification system in the new article, and you can always compare. So pre-plus disease would be mild arterial tortuosity and venous dilatation, and if it's more prominent, that it would go for moderate. Plus disease is when you have notable venous dilatation, arterial tortuosity, and when there is both venous and arterial dilatation and tortuosity, then it will be severe plus disease. Then if there's no ROP present, so you don't write no ROP anymore, you write incomplete vascularization. And if more than one stage is present, then you classify it as the more severe stage. Then again, there are some, in stage 2, you may find certain popcorn type lesions, which may on FFA look like these little tufts. This is not stage 3, and this is stage 2. Then extraretinal neovascular tissue may be associated with stage 3 ROP even without the ridge. So you might find stage 3 or extraretinal neovascularization, and even if the ridge is not there, it will be still stage 3. Then the term aggressive posterior ROP has been replaced by aggressive ROP, because AP-ROP was a term in which the main stress was regarding the nature of this disease, in which it does not follow through the stages, the extensive amount of hemorrhages in new vessels, and there's severe plus disease. So it had nothing to do with the zones. So now in the developing countries, it's seen that older babies also develop aggressive posterior ROP, and then it is more anterior and not so posterior. So now the term posterior has been omitted, and now it is just called anterior aggressive ROP. Then retinal detachment stage 4 is the same, a partial retinal detachment with or without fovea involving, but the term exudative retinal detachment has been introduced, which can occur in cases of ROP post-laser and pre-laser, and the term volcano retinal attractional detachment, which denotes detachment in which the periphery is intact, but the posterior pole is not. And this generally occurs if there's aggressive ROP, which is untreated and progresses to retinal detachment. Then in the previous classification, stage 5 ROP was classified according to the configuration on ultra B scan. And now they just want that, you know, you classify it on the bedside. So the simple thing is, if you can see the disc, it is 5A. Okay, if you cannot see the disc, then it's 5B. And if it is associated with anterior segment changes, for instance, angle AC shallowing, or the corneal is getting hazy, then it is 5C. So anything with anterior segment changes, it will go to 5C. Then the term regression. Now this term is very important in the current era of anti-VEGF. And so if there is regression, you report as complete or incomplete, spontaneous, post-laser or post-anti-VEGF. And then also it is very important to document the location extent of peripheral avascular retina. And now we know that in the current scenario, when we give anti-VEGF, even when it completely regresses, you find a zone of mostly zone 3, you find that it never vascularizes. So you must always document it, because things can go wrong, and at any stage in time. Reactivation after treatment, which may even include a new ROP lesion or vascular changes. And when reactivation of ROP stages occur, you have to put reactivated, and then you also have to classify it again, like reactivated to stage 2 or reactivated to stage 3. And then now they have also included long-term sequelae, again, in the current era of anti-VEGF. You're not ablating the peripheral retina. There can be multiple vascular changes in which there can be foveal aplasia, reduction in the avascular zone in the posterior pole. Then there can also be traction without detachment. And if there's aggressive amount of stage 3 and that has regressed, then there can be some degree of traction as well. So all of these are late sequelae which should also be looked out for and documented. Thank you.
Thank you very much, Dr. Sainam. And I'm going to take the next speech. So I'm going to present on who did actually get type 1 ROP. We are going to discuss birth weight characteristics in different stages of ROP. So as mentioned earlier, Pakistan ranks among the countries with the highest birth rates. This makes the number of neonates, infants, premature babies very high. It has a high population growth rate ranked which is measured as 2.9%. And along with this, there is high incidence of prematurity, which was labeled to be 28% of live births. NICUs are nowadays widely available. The survival of premature infants is improving. Higher incidence of ROP compared to the West was noted. In India, there have been found that 10,000 to 20,000 infants needed treatment for ROP, compared to only 300 to 400 infants who needed ROP treatment in the United Kingdom. But why is this difference there? Because there are trends for using concentrated unblended oxygen, because oxygen blenders are costly and there is a lack of availability of low-cost oxygen blenders. So it is very common to use unblended concentrated oxygen in our NICUs. There is absence of continuous oxygen monitoring per child. We may find continuous oxygen monitoring in Aga Khan, in Hamid Latif Hospital, but in other government setups, in hospitals, in DHQs, we do not have a single oxygen monitor attached to one child, so fluctuations in oxygen concentrations are not observed. There are no trends towards high oxygen alarms. The neonatologists, the junior neonatologists are very happy with 99-98% oxygen saturation in a premature infant, which is not there in the modern countries. So this makes a difference. Our study aims at identifying infants who actually developed ROP needing treatment, examining their birth weight and gestational age characteristics, and getting help to determine screening criteria for ROP services, which are now budding all over the country. It is a retrospective descriptive case series at Lahore General Hospital, which was held over 7 years after careful surveillance of all infants meeting the criteria of 2 kg or less or 35 weeks or less. We included all the babies screened for ROP, either recruited from our own NICU, which is a large NICU, or referred from another hospitals to compare the situation on both sides. We included all children having stage 3 in zone 1, stage 3 in zone 2 with plus, aggressive retinopathy of prematurity, stage 4 ROP, and stage 5 ROP.
a quick go through of stages from our own patients. This is stage 3 in zone 1, stage 3 in zone 2, and I'm showing a magnified view so that you see the vascular abnormalities going on beside the ridge in the periphery. AP-ROP, when there are flat fronts, as mentioned earlier by Dr. Khurram Mirza, flat fronts of ROP which are not extraretinal actually, but covering all of the posterior pole without a ridge. Stage 4 ROP with retinal detachment, but still the fovea is in place. This stage 4 ROP does not last for long. If it is active and there is vascular tortuosity, neovascularization, in few days it progresses to a situation like this, which is stage 5 ROP. Here we can see this child might have an aggressive ROP in the posterior zone, in posterior zone 1, and that is closed in this shape. Even a funnel is not formed on B-scan. This is another patient who is having retrolental fibroplasia, and his funnel detachment is obvious on the B-scan ultrasonography. We have screened about 2,000 infants over these 7 years. Of them, the majority was recruited from our own nursery, that is 1,534. We received 410 referrals with a note carrying high suspicion for ROP needing treatment. In our own patients, we found 99% ROP needing treatment, but in the referred cases, as these were already selected and screened elsewhere, we found as high as 40% ROP needing treatment. In our patients, trends were more for stage 3 ROP and also for AP ROP, but in the referred patients, as they were late presentations, more of them, 68%, had stage 5 untreatable ROP. If you analyze the patients having aggressive ROP, AP ROP, we found that 6 out of only 47 patients were weighing more than 1.5 kg. So if we follow the criteria, which is international screening babies 1.5 or less, we would miss 13%, which will multiply into very huge numbers according to the population of Pakistan. In stage 3 ROP, this percentage was even higher. 30.7% were having birth weight more than 1.5 kg. They had a birth weight ranging from 1.6 kg to even more than 2 kg. 30% of them weighed more than 1.5 kg among patients having stage 4 ROP. Few of them mentioned that we have been to screening setups, but they refused screening as our baby is heavy, but please have another look. Same is for stage 5 ROP. They were also never screened. Some of them were very low birth weight, so this was an inefficiency of the screening system at their place. Some were ranging from 1.2 kg to 1.5 kg, but a significant number again, 20%, were heavier than 1.5 kg. Seeing this graph, yes, we agree more of the patients, more than 120 patients were, yes, less than 1.2 kg, but a very significant number, about 110 patients, were in the range between 1.2 to 1.5 kg. Another very significant group, making 22.74%, was weighing more than 1.5 kg. This is a scatter plot. In this plot, we can see more number of patients because this is a 7-year report. The one presented by Professor Moin was up to 2019. Here we are including more patients with stage 3, with AP-ROP, so the number is more, and we can see darker circles which are corresponding to patients overlap. So we can see a huge population having more than 1.5 kg and also more than 32 weeks of gestation, which cannot be actually ignored. We are not alone in this situation. There are many other studies. This problem was mentioned earlier by Dr. Claire Gilbert. This problem was also seen in India, and they reported AP-ROP in patients weighing more than 1.5 kg. Big babies are also having ROP in Turkey, in China, in Malaysia, and also I have seen studies from Egypt, from Southeast Asia, from Latin America, from East Europe too, reporting occurrence of ROP in bigger babies. What is the reason? The reason is no high alarms. Premature babies are having up to 100% oxygen saturation. There is a term called double oxygen therapy, which is very common, and people come to say that our child was very sick, he was very light in weight, and he had very difficult breathing, and the doctor has been giving him double oxygen therapy, that's why our child subscribed. In such circumstances, we can expect ROP in bigger children. So let's go ahead and screen all children having 2 kg or less, and screen all children who are born at 35 weeks or less. Meticulous screening and early treatment is the only way possible. No other way is possible. A little delay, few days delay can make the situation change very rapidly from savable to non-savable. Let's do meticulous screening, because we don't want to see unnecessary leukocoria. We don't want to see this detachment due to ROP in these small infants. Thank you. I'm going to invite Dr. Arush to present situational analysis done in Pakistan about the centers who are doing RP screening or not doing RP screening. And after that, we are going to invite Dr. Arifa to tell us about the role of anti-VGF in ROP. Dr. Arush, please.
I don't think so. These are the new vessels, but there are a lot of abnormal branching of the new vessel. I follow these patients, but what do you say about these patients? It shows active disease.
This excessive branching, yes, is encountered in these premature infants, and it can be classified to 3 groups. The first group is neovascularization, the second group is telangiectatic shunting vessels, and the third group is choroidal vessels. In adults, choroidal vessels do not mix with retinal vessels, but when I was new at screening in 2015 and 16, I usually saw some choroidal vessels which were very highlighted, very different, maybe because these children have very thin retina. So we can, if you find that difficult initially, you will get to differentiate them over time, but following them on weekly interval is very helpful, because in case these are telangiectatic vessels or these are neovascularization, then of course progression will be noted.
But there is no mention in the classification, this abnormal. They say it's active.
Yes, it is not mentioned even in ICROP 3, the recent one. But yes, we all come across these branching prominent choroidal vessels. Dr. Khurram Mirza may have a opinion regarding this.
I'll just add to this. When you exactly these three things you have to differentiate between. So first look, if you're looking at these doubtful vessels, look if there is plus disease or not. So if there is no plus disease, then chances of APROP and other things are less. Okay. Then look at the caliper. So if the caliper is very fine, then you have to be careful, because they can be like new vessels. But if the caliper is not fine, okay, then most likely they are choroidal vessels.
Yeah, the caliber, mostly what I see is the caliber is not fine.
Yeah, so the mostly they are, I've come across many times, and look very carefully. That is the time when I actually get 20D rather than 28D. And I look at them with this, and often you can figure out that they are choroidal ones. Yeah, so then you can start relaxing. So if they're bigger ones, you can see in 2 weeks. If they're very fine, then 1 week.
Thank you very much, Dr. Khurram. Please, Dr. Arush.
Assalamu alaikum and very good evening. I'm Dr. Ruj Amjad. I'm working as Senior Registrar of Ophthalmology in Lahore General Hospital. I'd be presenting the situational analysis of ROP screening programs in Pakistan. This is a survey, and it's actually up till now, and it is still going on, and the results, a lot of emphasis has already been given to the screening, and I'm here to put some more. So the retinopathy of prematurity is a significant cause of blindness in children worldwide, as we already know. The data global is that 15 million babies are born prematurely each year, and more than 60% of premature deliveries are in sub-Saharan Africa. 13.4% of all live births in Southeastern and South Asia are premature, and the incidence is less than 8% in the UK. In Pakistan, 860,000 premature births are recorded each year according to the UNICEF 2019, and prevalence of premature births in Pakistan is 21.64%. So, according to a recent paper which has already been mentioned by Professor Moin Saab, that the third epidemic of blindness due to ROP has arrived in Pakistan, and premature babies are going blind even in the smaller cities. So, need of the hour, as we all know already, screening, screening, and screening. And this is to provide an overview of the current practice of screening and treatment of ROP in Pakistan. Many surveys are ongoing, many surveys are in progress, and this is one of a part of it as well. So a questionnaire was sent out to general ophthalmologists, pediatric ophthalmologists, video retina specialists of different hospitals in various districts of Pakistan. The total responses we got were 68, and out of these, 28% had proper ROP screening set up, 20% had treatment facility for advanced ROP, 14 out of the 19 centers which were present. There was no proper setup, but screening was done on call in 11 setups as far as our survey is concerned, and no screening facility was available in 38 out of the 68, which is 56% of the data. Referral was done in 63% of the cases. So there must be some centers missing in it as well, because as we know, it is according to the response that we got after the survey. And in the Punjab, 12, in Sindh, 5, and in KPK, 2 centers reported. And in Peshawar, the Lady Reading Hospital, while we were doing the setup, they were establishing the ROP screening program, and now they have established it. From Azad Jammu and Kashmir in Muzaffarabad, screening is done on on-call basis. There is not proper setup, but screening is done on the on required, as and when required basis. So the number of teaching hospitals in Pakistan, according to Pakistani Foreign Medical Student and Graduate website update, is as you can all see on the screen, and the total teaching hospitals in Pakistan in the public and private sector is 55. More than 1,200 public and 700 private hospitals in Pakistan are reported by the Healthcare Resource Guide Pakistan in 2016. So we have so there should be a lot more dedicated ROP screening setups in Pakistan so as to prevent the childhood blindness by providing proper treatment as a result of timely screening. And thank you very much. Our world is beautiful because we can see it. Thank you.
Assalamualaikum. Already Dr. Khurram Mirza has discussed role of anti-VEGF. I'll just share our experiences. I'll be presenting here management of ROPs type 1, especially type 1 with anti-VEGF, on behalf of Professor Dr. Azizur Rahman. My name is Dr. Arifa. I work at Jinnah Postgraduate Medical Center, Karachi. I have no financial interest to declare. Our objective is to share a little experience of management of type 1 anti-VEGF, especially with ranibizumab. We are not using bevacizumab. Premature infants have been screened and treated accordingly at our center since 2014. ETROP classification already been discussed, so I won't go any further. Two anti-VEGFs that are commonly used in ROP, bevacizumab and ranibizumab. Why ranibizumab? BEAT ROP study was the first randomized clinical trial discussed previously. It's useful for ROP, but it has been reported for late reactivation as well as for developmental delayed milestones, and local and systemic toxicity is not known yet in infants. So we have come towards rainbow study. Success is around 80%. It's FDA approved, and 0.2 mg is well tolerated dose in patients with ROP. So it's now there's a rainbow extended study, which study is to follow patients up till 2 years, 2 to 3 years, and monitor the effects of these ranibizumab injections in infants, and accordingly they are managed. They are compared with laser therapy. So the interpretation was the 2-year outcome following ranibizumab 0.2 milligram for the treatment of ROP confirms the ocular outcomes of the original rainbow trial and show the reduced high myopia with possibly better vision. However, this treatment did not appear to affect non-ocular infant development, so it's basically systemically safe for infants. This is a technique that has been protocol that we have developed, and it has been I'll discuss we have grasped from short needle of around 4 mm, antiseptic antibiotic 5% to 10%. Follow-up should be 48 to 72 hours post-injection. Extra attention to fine details and clean environment site, especially 0.75 to 1 mm, and recheck every 1 to 2 weeks following injection until mature vascularization is achieved or laser is needed. What JPMC we do is we follow around 56 to 60 weeks post-injection. This was developed from a retrospective review investigating the safety of this technique. It's done by Austin Retina Associates and Boscombe Palmer Eye Institute. They revealed no cases of cataract, endophthalmitis, or vitreous hemorrhage were reported by using this safer technique. This is the protocol that JPMC has now recently developed for past 3 to 4 years. A short needle of 31 gauge with 5 mm. Prerequisite for intravitreal anti-VEGF has been developed along with the National Institute of Child Health, CBC, as Dr. Khurram Mirza has said, and C-reactive protein. CBC, sir said about the level of hemoglobin. I would like to add one more thing. What we else see in CBC, complete blood count, is the level of platelets, number of platelets. What prerequisite is that platelets should not be less than 1 lakh. If they are less than 1 lakh, then you should not inject anti-VEGF and wait, and C-reactive protein levels should be within range, not more than 0.5. If C-reactive protein levels are elevated, it means there is some systemic ongoing infection is going on and you should wait. Antibiotic eye drops 4 times a day before the procedure. Steroid eye drop once a day started at the time of initial examination and diagnosis. Why steroid? I'll share later. These are few pictures. Recently, Jinnah Post Medical Graduate Center has got a Phoenix Icon RedCam, and this is a 30-weeker child, 1.4 kg weight with oxygen on 12 days. Was presented with zone 1 stage 3 disease, pre and post ranibizumab in right eye. The third picture is 1 week after, as sir said, Dr. Khurram said that after 3 days you won't be able to believe it's the same eye, but you need to follow. The same patient with the left eye. Another picture of a patient, 1.6 kg, 33-weeker, oxygen given for 20 days. As you can see, the aggressive posterior plus disease, posterior pole. And this is a picture, third picture is after 1 week. The same patient, left eye. And the right eye of a 32-weeker, 1 kg, oxygen given for 18 days. Now you can see there's a, there's a ridge with the new vessels and at the end of zone 2, and it was treated with ranibizumab, and this is the left eye of the same patient. While right eye of this 32-weeker, this patient was referred from elsewhere, 1.3 kg, oxygen given for 25 days. This is the left eye picture of the same patient. Now the question is, do we repeat intravitreal ranibizumab, or is there any chance of disease reactivation? Yes, we do repeat, and yes, there is a chance of disease reactivation, but we do not repeat before 4 to 6 weeks, and if there is a need and warrant of laser, then it should be done timely. While ranibizumab is an antibody fragment with a shorter half-life, it is possible that recurrence rate after initial first injection might be higher, as it's rapidly clear from the eye as well as it's rapidly clear from the system compared to ranibizumab. So this was a picture of a patient with the reactivation And the second dose was repeat after 4 weeks, and you can see the picture down. Now we have a new thing is beta blocker, new treatment for ROP. It's in the second phase 2B study, and it shows that propranolol 0.2% micro drops can reduce ROP progression when administered during proliferative phase of the disease. It's well tolerated even in preterm with the high prevalence of comorbidities, and propranolol 0.2 is initiated in progression of stage 2 to 3. A Swedish study as published in Ophthalmology Retina Review has investigators have found that dexamethasone topical can avert progression of pre-threshold type 2 ROP to type 1. Dexamethasone is thought to decrease severe inflammatory mediators and subdue vascular endothelial growth factor. Therefore, we have started dexamethasone 1 drop a day at the time of examination and diagnosis. The conclusion is that the actual injection is not the only important aspect of this process. The whole process needs a detailed, close follow-up, close examination to monitor and treat for infection and to ensure mature vascularization has occurred. Laser should be performed if vascularization has not occurred in due time course. Do not wait for vessels to come on their own. Please do give lasers when needed. Thank you. Any questions? Sure, sir. So we are not giving propranolol yet. We are giving dexamethasone. If I'm able to take a generic name. So we have started Mexidex eye drops at sleeping time. But we have not started propranolol because it's not published yet. But I've just discussed this, that this is the new thing that you can give. Why we have not started propranolol? Because propranolol can lead to systemic cardiac effects in neonates. You do not know about that. कि heart rate पे उसका क्या role होगा आपको नहीं पता. So since the dexamethasone is known, तो फिर we have started dexamethasone.
I was also waiting for that study to be completed. That's why.
Because I think a year back when I read this study of dexamethasone by someone and I posted it to Dr. Lubna, I posted it as well. I think they were this study was encouraging according to the investigators. The other propranolol we are already using, especially in the hemangiomas, and but under the supervision of the pediatrician, and that is even more. You're giving it systemically, and we are also using it topically on the children with glaucoma.
But they are
so
bigger
I think we can.
But they are bigger.
Yeah, they are bigger. Yes.
And sorry, sir, one more. They don't have those systemic disease process going on as compared to neonates who are premature.
Yeah.
So that's the point that that's why we are not giving right now.
Right. Yes. Thank you.
Thank you very much. Now I will ask Dr. Ahmed Rushdi for conclusion remarks, please.
Okay. So I will just give a few advices to my new colleagues regarding anti-VEGF and laser. So when you inject anti-VEGF, you will see a very rapid response. So you will see a marked response within 2 or 3 days. But when you do laser, you will see a response which is delayed, maybe 2 or 3 weeks compared to 2 to 3 days after anti-VEGF. The second point regarding laser is that when the child is not fit for general anesthesia, I go for subtenon anesthesia with sedation. So
that is good.
This decreases the apneic spells, and this help to maintain pupillary dilatation during my laser.
So what type of sedation do you use for these children?
So usually we use a rectal sedation.
Okay. Actually, my anesthetist is very uncomfortable with sedation. She says that some children hold their breath when they are sedated, and we don't have a tube in place, so nothing in our hands. So better either you do it totally under topical anesthesia, local anesthesia, or let me intubate the child.
So usually he gives a mild sedation. So
yeah.
It is not very sedated. It's very mild sedation.
Okay, that is good. And you are pretty comfortable with that?
Actually, in most of my cases, I go with general anesthesia.
Right.
This is
Yes.
Only
only in special situation where general anesthesia cannot be performed.
That is very great. So these institutes are lucky. Like Hamid Latif Hospital also has expert anesthesia personnel who are trained in anesthetizing those premature infants. So in our setup, some hospitals are having this problem, as mentioned by Dr. Khurram Mirza, that the anesthesia department clearly refuses to deal with these children. So we have to then give them some lasers under topical anesthesia. In my practice, I start doing concentric laser sessions. So one session is only on the indent near ora serrata, allow the vessels to grow further. Next week, give another session, and they may or may not require the third session. So do not fill all the area with lasers. But it is really difficult handling children with in topical anesthesia.
Okay, the last point I want to discuss. If
Yes.
you inject both eyes at the same time,
Yes.
do you lower the dose of anti-VEGF? Or
Yes,
still
we
use
use
the standard
half
adult
adult dose, and once Dr. Khurram Mirza mentioned that even 1/8 is enough, sir.
Actually, nowadays they've done a few studies, and with the on ranibizumab, on the systemic safety of that, they have recommended actually you can increase more than more than half.
More than
So I
half.
just give half.
So usually when I inject both eyes at the same time, I give force to the adult dose.
Right.
For actually because to decrease the risk of systemic
Yeah,
absorption.
yeah.
Yes.
And also the
There is
systemic
a study
absorption
saying that
enhance the
1/4.
effect of anti-VEGF.
Okay, that's a good point.
So debate is still there whether to use 1/4 or 1/8 or more than half. Maybe half adult dose is the intermediate solution.
Yeah, so that's why we can, and I think obviously we've done hundreds and hundreds, and I've followed up those kids.
So did you
I've
see
followed
any
up those
mortality
kids.
following intravitreal anti-VEGF?
Excuse me?
No.
Did you see any mortality following intravitreal anti-VEGF?
Mortality.
Mortality or death
No,
or
no, I didn't, I didn't see
respiration,
any. I didn't see-
respiratory events?
No, no, I didn't see any.
I really have seen that. I don't know if it was really related to the anti-VEGF that I gave, or maybe the child was already sick.
Yeah, I'll tell you what. I had one mortality 2 hours before I was going to give injection.
So lucky it was before that.
That baby could have delayed for 2 hours, and
Yeah.
then I don't know what would have happened. It just happened 2 hours
That
before.
is the major
So,
bias.
you know, they are at risk.
Yeah.
And it's the same thing as AMD. AMD happens in elderly population, and they have
Yes.
other comorbids. So it's the same
So when
thing,
they
but
receive
when
anti-VEGF,
you-
they may get
when-
some
when you
episode.
get one iffy incident in
Yeah.
few hundreds,
It is saving
That's not
hundreds. Yeah, it is saving more than hundreds.
The infant has expired, and
Yeah.
the reason was told that he has developed renal problem because of anti-VEGF, but we didn't found any record for this.
It may or may not be due to anti-VEGF. It may
Yeah.
be just a coincidence. But I've developed a protocol counseling the patient that you are receiving an intravitreal injection. It's better you get an RC's admission for 24 or 48 hours. Some parents agree to do that and some do not. But I tell them that the child is sick, we are giving anti-VEGF, there is little chance of systemic absorption. So if you go for nursery admission and get your oxygen monitored, it will be safer for you.
So do you inject aflibercept?
Dr. Khurram Mirza did.
yeah, I've done a few of them, not as a routine. We knew that I was told that you can't do any laser or anything for a couple of months. Baby was having other things done as well. So that's when I injected aflibercept. And I kept observing, I kept on checking and all that. So I've done about 4 or 5 aflibercepts.
Did
maybe
those
6.
children need
And-
laser later on or not?
But you see, with ranibizumab, we noted that it would stay quiet for 4 weeks.
Yes.
And 5th week, it may.
Flare up.
These days, I'm noticing that they are flaring up after 6 or 7 weeks because of original better oxygen protocol. But aflibercept, nothing happened for 2 to 2.5 months.
So we have injected a lot of kids with aflibercept. We noticed that in these eyes, the vascularization is more physiological. We are still collecting that on this, but we feel that the vascularization after aflibercept injection is more physiological than ranibizumab or bevacizumab.
That is quite
And
possible.
no,
Yeah,
it is not required any further lasers later on.
So, but
They vascularize on
actually,
their own.
I was afraid of using that too much because you see ranibizumab is being used a lot. This wasn't, so I just used it on my own. But you know, for indications and everything. But I think we should look into that, and if we should do a study on that actually,
So,
comparison. Yeah.
while doing laser, to how much extent do you go near to the posterior pole? I mean, till the vascularization.
As much as needed, because that is why you see before these injections we used to do lasers, and if there was a posterior disease, I do it till that demarcation line or that different or ridge or whatever. I always do 1 or 2 rows behind the ridge as well. Okay, that the Americans they said no, don't do behind the ridge, but I have seen everything settling down, but that ridge contracting a little bit and causing slight drag in the macula. Why do you want to have a drag when you can have just 1 or 2 lines behind the ridge, thin lines? So if that is coming inside the macula, or too close to the macula, that is the indication for anti-VEGF.
Sir, but the scars of this diode lace, especially, they expand over time. So have you seen any such expansion which is involving the macula?
Well, I stay quite clear of the macula. So even if they expand a little bit, they do, because when you're doing this, after that the whole thing is laser. So they do expand a little bit, but that's why you want to be safely away from the macula. And if you're not safely away, I think that's an indication for anti-VEGF.
Thank you.
So what type of laser you are using? Diode or green laser?
I am using green laser. Getting a diode very soon, so I'll shift over to diode. Yellow laser, sorry. So that's usually best recommended for ROP.
So do you feel that there is a higher risk of cataract with green laser than diode laser?
I don't feel that.
Because there is
I had that horrendous complication called anterior segment ischemia. I had one patient. And that is usually so after that I was very careful with 3 and 9 o'clock because if you're heavy on that area, you can cause that, but just one out of so many. So in that patient, cataract did develop. In that patient, the cornea became white 4th day, and there was oozing from the iris. The eye was soft. I looked everywhere, and I found 3 or 4 7 case reports. I rang Umar Mia in New York as well, and I said, have you had this? He said they had 2, and they did vitrectomy and everything, and they lost the eye. They were lost. So what I did was, looking at all those cases, whatever they tried and everything, I put the baby on high steroids, topical as well as systemic and everything. Well, within 2 weeks, the cornea came back, everything, only cataract happened, but everything else settled down. The baby is still, the baby is big now. So that was one case. And other than that, no, not really.
So I have both. What I usually do is that usually I go for green laser because I feel it's more controllable than the diode laser. But I go for diode laser if there is tonica vasculosa lens. Because if there is tonica vasculosa lens,
Yes.
still there is a higher absorption of the laser energy by this tonica vasculosa lens when you use the green laser. So there is a higher risk of cataract too. Is this the only situation when I am using the diode laser?
If I find that, I usually give anti-VEGF, and that also disappears.
Yes.
That also disappears. So, thank you very much, everyone.
Thank you.
I don't know what session is going on there. They're calling me in the other session. This is too late. So, thank you very much, especially